Well, good afternoon. We're finally bringing it to a close. It's been a great day and a lot of clinical pearls shared. I want to thank Dr. Meyer and Emily for inviting me to be a part of this day. It's been really um, fascinating. When I first got the call to participate in this day, I thought, oh boy, I'm not sure how much I know about health literacy, but then I thought about the topic of palliative care and how we certainly intersect with health literacy and thought, yeah, I think we probably do have a lot to contribute to this conversation. So I'll center my comments around health literacy and palliative medicine in the context of a large health system. I want to start by telling you about a patient, and her name was SW. She was a 61-year-old Navajo American woman who I met in the ICU. She was critically ill. She looked like she was actively moving towards the end of her life. She had a history significant for autoimmune hepatitis, hepatocellular carcinoma, and hepatitis B. SW had had many of the complications that we see in sick patients that are in ICUs. Her kidneys stopped working, so she was on dialysis. She had a respiratory arrest, so she was on a ventilator. Um, she went into septic shock, and so she was on very strong medications to squeeze her blood vessels very tightly to increase the blood flow to her heart. And she had actually been listed for a liver transplant, but she was delisted because she was so sick. And the ICU medical director called me and said, you know, we really are at an impasse with this family. They don't seem to get what's going on here. We don't think that she's going to leave the hospital. And would you be able to help us and talk with them and figure out what their goals are, what's important to them? So our team is very busy, as we usually are, and we divided and conquered that day. So I went to the ICU to see Miss W and meet her husband. And I walked into the room and I was struck by this very tiny little woman who was very jaundiced, who was connected at every orifice to something in the room. There was so much equipment around her. And if I didn't walk around the side of the bed, I would have actually missed her husband. And he was just kind of sitting there very quietly, tucked between the bed and the ventilator. So I pulled up a chair, I sat down, I introduced myself to him. I asked him if he wanted to talk someplace other than his wife's room. He said it was okay to talk in his wife's room. I next asked him what sort of communication style was important to him. How would I best honor him by talking with him? Because, you know, with many of our Native American patients, talking very directly about things like possibly death and dying is really a taboo. It's a no-no. But Mr. W told me that he wanted me to kind of, you know, be straight up with him and give him the facts about what was occurring with his wife. So I moved forward and I asked him to tell me about his wife. He said they had been married for over 20 years. He said that they had many children. He described her as being very independent and very vibrant and, you know, enjoying going to the mall and just being able to do those nice things for herself. She had really pretty nail polish, I noticed, on her hands and her toes. She liked having pedicures and manicures done. And so we talked about that for a little while. And I next asked him about his faith, his spirituality, if that was important to him and to his family. And he said, you know, doctor, you know, we really believe in the Creator, and we think that the Creator gave us water and fire and air. And so, you know, was beginning to kind of understand a framework with which he could use to justify the treatments that his wife was getting, the blood clot products and the IV fluids coming from, you know, fluids and water and the Creator ultimately. I next said to Mr. W, you know, I asked him, what do you think is happening here? What are you seeing when you look at your wife? And he was quiet for a moment and he looked at me and he said, you know, it looks like she's dying. And so we took a moment and paused. And then he said, you know, doctor, 6 years ago, my wife was at another hospital in an ICU and she had machines going. And the doctors told us there that she was probably going to die too, just like the doctors told us that here. And he said, you know, most people think that there's a heaven and a hell, but he said there really isn't. He said the afterlife is like going past all of the stars and all of the galaxies and all of the planets. And he said that's where my wife was. And she told me she was with her ancestors. And she told me that she felt a lot of peace and she felt a lot of love there. And he said she looked back and she said to him that the earth was so insignificant. It was very tiny, like this insignificant little speck. And he said, we were doing a ceremony, doctor, with our medicine man, and he was blowing the eagle bone whistle. And so I didn't know what that was. I had to look it up later. But the eagle bone whistle is a sacred religious musical instrument used by Native Americans, and it's made from the long bones of eagle wings. And they are considered to be extremely powerful spiritual objects. They produce a series of high-pitched notes that are reminiscent of the cry of an eagle. And they're only used in ceremonies to call the spirits. So his wife was in this place with the ancestors and feeling peace and love. And she heard, her husband told me, the eagle bone whistle. And she knew at that moment that it wasn't her time to die. And so then she described to her husband immediately feeling like she was moving very quickly. And she said that she was moving past all the galaxies and she was moving past all the planets. And all this while, with all this movement, she kept seeing the Earth, which was like a speck, but now it was getting bigger and bigger and bigger and bigger until all of a sudden she kind of stopped above her body, and then she was in her body again. So you can imagine that was a very, very powerful story, and we were silent for a minute. I mean, you can't fill that up with words. And so I looked at Mr. W. and I said, well, Mr. W., it sounds like we need to go back to the reservation and have a ceremony and blow the eagle bone whistle. And he said, yes, doctor. So I left and went to find the ICU director, and I said, listen, we've got to continue what we're doing, the weekend trial of critical care. They've got to go back to the reservation. They've got to do the ceremony and find the medicine man and blow the eagle bone, and then we can go from there. And much to the credit of the ICU team there, they said, absolutely, that's fine. We can do that. So on Monday, I got a call from the ICU nurse, and she said, Dr. Pinderhughes, there's a room full of people here. There are about 20 people in this ICU room. You better get up here. So I went up to the ICU, and sure enough, there was a room full of her family. And I walked around the side of the bed and found her husband sitting in the same chair that I had left him in on Friday. And I sat down, and I said, Mr. W., did you have the ceremony? And he shook his head, and he said, yes, doctor. We blew the whistle and she didn't come back. And so the family at that moment decided that it was time to focus on aggressive comfort and dignity measures. And I shared this story to say that I think that palliative medicine really is a natural fit for healthcare literacy. I think that the key elements of palliative care service delivery and what we do really create that environment that we heard about earlier, talking about sort of emerging health literacy. It creates an environment for that to happen, much like we saw with SW. It's really an intervention that is focused around aligning with patients around their goals and their values, what matters most to them. I took this conceptual model from Dr. Meyer. I mean, she was really the first one that described this, and this is really kind of what we do, what the palliative care intervention does. It is a dedicated team made up of different professionals. Somebody talked about that earlier, with different skill sets to meet the needs of complex patients, and that team is able to spend the time and focus with patients and their family members, and that comes to a point where we're able to make decisions, and we're able to have clarity, and we're able to align around values. So at Banner, I think that one of the ways we try to leverage this across our healthcare system is through a system, large sort of education team, and then specifically interventions that the palliative medicine team is bringing to our system. So let me tell you a little bit about us. We are a large healthcare system across 7 states. We have 28 hospitals in our system, from Alaska to Nebraska. We just acquired the University of Arizona Health Network, which is the medical school down in Tucson, University of Arizona, and Phoenix campus, along with 2 acute care hospitals, a cancer center, and a pediatric hospital. We're large. Banner Health Network has a number of lives that we are responsible for in varying degrees of risk. We have over 1,500 doctors just alone in the Banner Medical Group side, and that's another 1,000+ doctors with the acquisition of providers in Tucson that we've just acquired. So we're a large healthcare system. We also have over 19 GME resident and fellowship programs across our healthcare system. So this is really a snapshot of the palliative care program, and I want to just kind of go through this a little bit because this, I think, speaks to, from a health literacy perspective, what we do in palliative medicine. The palliative medicine program is viewed as a system program, so it is one program. And this is sort of our strategy map and a snapshot in time, if you will, of what our system program looks like. So we have a high-level executive sponsor. Within Banner, palliative medicine is highly supported from our CEO, Peter Fine, down. So we have a senior-level executive sponsor, and then the program rolls up under my leadership, and Banner does everything through dyad partners. So we have a dyad partnership. And really, our vision is expanding palliative care on the inpatient side. We have about 8 hospitals now, 12 by next year. Expanding palliative care in the ambulatory setting, we have a home-based program and are moving towards 2 large ambulatory programs. And then we have this new fellowship residency program that we've just started. We just took our first 2 fellows starting in July. But I want to talk about this arm here of the primary palliative medicine tools. I think that Dr. Meyer had it right this morning when she was talking about health literacy being a problem of us, the providers. And I think that we do great work at Banner for the patient side, but on the provider side, I think that there's room to grow. Banner Health uses clinical consensus groups, and we have about 23, and palliative care is the newest clinical consensus groups. And these are the bodies across the system that develop clinical practices that affect patient care. So in other words, within pediatric asthma, how are we going to deal with patients that have pediatric asthma? What intervention will all of these patients receive that's such that it will be standardized, and we will try to reduce that care variability. So the CCGs work together, and we use a methodology called define, design, and implement. And so through that, we develop these evidence-based clinical practices. We work collaboratively with appropriate CCGs, and then that rolls out across our entire system, across all 28 hospitals. And so that's one way that I think we can affect healthcare literacy. The other way that is important for us at Banner is really equipping primary care providers with the tools to do primary palliative care. So we work really closely with the CAPC curriculum. I think about 7 or 8 of our hospitals are members of CAPC. So we are doing an initiative with our doctors, for example, around pain management. And then we will be engaging our providers, our hospitalists, our specialists, other providers around the communication modules and those sort of primary palliative care skills that all providers should be able to do that I heard some dialogue about earlier. This is an example of our Patient Education Resource Center. So we have a system team. Banner is all about sort of, as I said, standardization. So everything that we do rolls out across the healthcare system, and I think that that's very beneficial because you don't see a lot of fragmentation. But we have a system education team that is very involved around healthcare literacy. All of our publications are at a 5th grade reading level. You can see there are a number of different resources for providers to access around health literacy, around informed consent. All of our nurses actually do teach back. So that is something that every single nurse within the Banner Health system that is hired is onboarded on teach back. And on our floors, they start this, at admission with a patient. They do it every day of the hospitalization through to discharge. So it's a very integrated process to try to ensure that our patients are really able to understand and process the information and take it with them from the hospital and then implement it when they're home and when they're in the community. So I will summarize this. At Banner Health, health literacy is a priority for us. Our system patient education team really does a deep dive around materials that are appropriate for patients. They bring in also a council of community members to review these documents before they even are implemented in the facility, because we may think they're great, but when we show them to our stakeholders in the community, there may be things that need to be improved. All of our nurses, as I said, do teach back, and we have that as part of the onboarding. And then I think from a system palliative medicine perspective, we continue to grow within our CCG, and we continue to focus on how we can equip providers with tools to deliver primary palliative care, those basic skill sets that every provider should have. And we will continue, I think, now that I'm thinking more about health literacy and have gotten a lot of great information today from colleagues. We will continue to see how we can improve the experience for our patients. Thank you.